When it comes to diabetes per se, there are a few clear-cut indications where the benefits of RAS blockade has been very, very clear. One is the heart failure with reduced ejection fraction, about which I'm sure Dr. Manokar is going to talk a little bit after that later, so I don't want to touch that. The second indication is diabetes with systemic hypertension. Now, it has become so common garden that even the guidelines, all of them say the first line treatment is going to be an ACE inhibitor or an ARB, in addition to other drugs. So the first thing is going to be RAS inhibition. This is the European Society of Cardiology recommendation. This is the same in every recommendation. The A is going to be there all over the place. Now, how much of the diabetics does this comprise of? Now, the incidence of hypertension in these diabetic patients varies from 50 to 60, 15 to 60%, but ultimately, I think we boil down to 50% of patients. So what does this mean? 50% of the patients are going to get RAS inhibition. So that's clear. So that brings us to the next question of what about the diabetes with a little bit of problems? Now, we all know that diabetics do not have an albuminuria. Over years, it progresses to microalbuminuria and then goes into nephropathy. Clear-cut data has emerged in this group also. The IRMA2 in the microalbuminuria, and then the subsequent renal and the IDNT with macroalbuminuria, and even the Benedict trial with the enalapril, all have clearly shown some benefits and delay in the progression of diabetic nephropathy. Now, this has not been translated into normoalbuminuria patients. Now, in this particular trial with Jennifer Well, you will see that in normoalbuminuric patients, between placebo and then losartan, there was not much of benefit. The only trial that showed some benefit was the roadmap trial, but here in the BP reduction was a big problem because BP reduction was significantly more with olmesartan, so this cannot be taken as too much into account. So we're not sure about the normoalbuminuric patients, but if you develop a microalbuminuria, clearly there seems to be a benefit in these group of patients. So we have three indications clearly in diabetic patients. Now that brings us to the next question of patients. Are the diabetic patients at high risk for cardiovascular events? Now, when it comes to this, the biggest trial to fame has been the 2000 trial, that is the HOPE trial. Now, you must understand a few factors about the HOPE trial. HOPE removed the few patients which clearly had RAS inhibition benefits, the heart failure, the uncontrolled hypertension, on less than 4 weeks of stroke, MI, and the overt nephropathy. We have seen the benefits of this already. So what the HOPE trial used was 55 years of age and ASCVD, or a diabetic plus one risk factor, which accounted to about 38% of patients, which could be smoking, hypertension, cholesterol, low HDL, or a documented microalbuminuria, and of which only 47% were hypertensive. So we are looking at a big chunk of patients without hypertension taking RAS inhibition. Now, the entry-level blood pressure was 139/79. It's not hypertension at all. And what about the benefits? Clear-cut benefits in the cardiovascular events, nearly 22% reduction, clearly showing the benefit of RAS inhibition in these high-risk group of patients. Now, this was subsequently replicated by the Europa trial also, but the difference was that in the Europa trial, 1/3 of the patients were less than 55 years of age, including the lesser age group patients. But once you started including these patients, the benefits obviously started coming down. But the amount of lipid lowering was nearly 58%. Now it's going to be 100% in today's data, but that has also improved. So what has happened is the HOPE and the Europa clearly showed there are cardiovascular mortality benefits in stable coronary artery disease. So we've expanded to one more indication from the albuminuria, now we move on to stable coronary artery disease. Now, what is left with? Those patients who do not have this problem, but who have high risk. Now, this is a comparison of the HOPE and the micro-HOPE. Micro-HOPE is the diabetic subset of the HOPE trial. So if you look at the blue panel, which is the HOPE panel, and the micro-HOPE is the orange panel, you look at the overall results, the orange seems to be higher than the blue, clearly showing that the diabetics benefit much more from RAS inhibition. Now, why, how? We have to be a little clear. In this high-risk group of patients, it is clearly beneficial. How much, we'll have to understand a little differently now. Now you start looking at diabetes. Is there a low-risk diabetic? No. This is the European Society of Cardiology recommendation in 2019. They said the diabetics start with moderate risk. The moment you have a diabetes and any of the risk factors like age, hypertension, dyslipidemia, smoking, or obesity, you're going to have a clear indication for a high-risk patient. So most of the patients are going to be more than 10 years diabetes with at least one target organ damage, or two, it's going to be a high-risk additional factor. So they are going to fit into the high-risk category. But do all diabetics need it? You must understand that this is going to be predominantly there. And if you look at the ICMR INDIAB study, nearly 79% of the patients had dyslipidemia. So what is going to happen? 79% of diabetics are going to fall into the high-risk category without any other consideration. Just look at the lipids. You're going to have a dyslipidemia, so you're going to have 80% of the diabetics who are going to get into some kind of a RAS inhibition. What about the rest of the 20%? Now, this is where you have to understand the RAS inhibition a little bit to understand why we need it in that group of patients. Now, you look at the RAS inhibition, there are two receptors, the 81 and the 82 receptors. Now, there are two kinds of actions. One is the circulating action, which we commonly know, the hemodynamic actions, vasoconstriction, sympathetic activity, epinephrine release, and the long-term effects of salt and water restriction. But there are tissue RAS actions, which are the non-hemodynamic effects. Now, this happens as hypertrophy, local proliferation, fibrosis, inflammation, and oxidative effects. This is going to be the tissue inhibition or a tissue RAS action. Outside this, there is an 82 receptor action that is actually beneficial. Now, if you understand this, you'll have to understand what happens in the heart. Now, the heart actually has got the renin, angiotensinogen, ACE, and the angiotensin 2 receptors all are present in the heart. Now, we have been thinking that it's all not there in the heart. Now, all these are actually present in the heart, and tissue inhibition is pretty important there. Now, these are upregulated in myocardial infarction and heart failure. Also, you'll notice that fibroblast macrophages and endothelial cells also contain this, and angiotensin 2 is harmful. So we have seen that. So what happens in normal situation is not only this. So the mechanism of action of ACE inhibition also has some other additional interesting facts. It is not the conventional RAS inhibition that we saw. There is an alternative pathway called the non-ACE mediated kinase pathway. And there is a secondary pathway called the MAS receptor pathway, which is through the ACE2 gene. Now, what happens is the ACE2 gene converts the angiotensin 2 to Ang1 to 7, which is actually beneficial. So if you have an effect in these patients, the angiotensin 1 to 7 has got beneficial effects. It actually prevents the hypertrophy inhibition. But there is an increase in hypertrophy, and all the tissue effects happen with angiotensin 2, the aldosterone, and even the prorenin has been found to be harmful. So in clinical effect, what happens is there is a balance between the angiotensin converting enzyme and the ACE2. When the ACE2 is predominantly there, it is beneficial. The angiotensin 1 to 7 is there, it is predominantly beneficial. But if the balance tilts towards the ACE gene, then you develop cardiovascular disease, clearly showing that there is going to be a problem. Now, what happens in diabetes is interesting. I'll take you through one trial, which is a very old trial published in 1999 Lancet with the CAP trial. They wanted to find out the benefit of captopril, and they found out there was no significant benefit. You look at this. But when you start looking at stroke, MI, cardiovascular death, nothing, and death, diabetes, nothing happened in these group of patients. But when you look at the CAP trial, look at the diabetic subset and find out what is the benefit of the ACE inhibition or the RAS inhibition. You look at what happens here. The stroke, CVMI, death comes down significantly, captopril better, mortality reduction, myocardial infarction better, stroke, which is much on the right, comes to the neutral line. So clearly showing that there is going to be a benefit. Now, why does this happen? We must understand what happens in diabetes is not common. In diabetes, the first thing that happens, there is an upregulation of the ACE gene. That is one. The second thing is there is going to be hyperglycemia induced increased responsiveness to the angiotensin 2 receptor effects. Third is the alternative pathway. The kinase pathway works more, generating more of angiotensin 2. The next thing is that there is a reduction in the angiotensin converting enzyme 2. So the protective effect of angiotensin 1 to 7 starts coming down. More than all this, you also have an increased prorenin effect. We also know that the glycation end products can directly be harmful by their oxidative mechanism. So the activation of this pathway in diabetes is going to produce all the harmful effects that we have seen. Cell growth, apoptosis, oxidative degeneration, inflammation, fibrosis, and all these will produce a negative remodeling or a poor remodeling and atherosclerosis. So with this in mind, there are several new ideas that have come in. The spironolactone, eplerenone have been tried, but the problem is there is a very poor selectivity of spironolactone. Eplerenone is not that very effective in this. The renin-prorenin inhibition is being tried. The S2 replenishing strategies, angiotensin 1 to 7 administration. These are all future strategies, and all these studies are going on at this point of time. So summarizing whatever I have said so far, what has happened is we have seen that diabetes with systemic hypertension, 50% of the patients are included. Heart failure with reduced ejection fraction, stable coronary artery disease, and high risk for coronary artery disease and the albuminuria. If you look at all these criteria, 80% of the patients are going to be benefited. What about the remaining 20%? Why is it that we don't have data? You must understand that this process of atherosclerosis is a slow process, and that is mediated by the RAS inhibition. Now, long-term use is going to take a long time. That is where we don't have the data. But bench studies are useful. But clinically, is it going to be useful in the bedside is a big question mark. But if you look at the high risk of diabetes, I will take you through the Lipidization of India Guideline Committee recommendation. There is not even a moderate risk diabetes. All diabetics straight away fall into a category of high risk, indicating that all these patients will benefit from RAS inhibition. So we have clearly seen that systemic hypertension, albuminuria, high risk diabetes, coronary artery disease, heart failure with reduced ejection fraction are all beneficial. Should we say yes to all diabetics? I can only give you the data that it will be theoretically useful, but practically is it going to be useful? I think you have to think for yourself and take a call by yourself. Thank you very much for the patient listening, and I will rest my case here. Thank you so much, and back to Dr. Ajit, sir.
Thank you, Prabhakar, for a very lucid presentation. So, where we went through what is the data available in each category and leaving open the question of those 20% where we have maybe bedside data that it may benefit, but long-term data, we need outcomes to maybe decide whether every diabetic would require it. And we would discuss it in the panel further as to how we dissect that group out and see how we can see what can be beneficial to them. So we possibly will go to the next lecture, and this is a very, very important lecture. And Dr. Manokar, I'm sure, who's an excellent speaker, would provide very good value to this lecture, where we are taking on two problems. One is myocardial infarction, and the end product of which may be heart failure. And we combine those two issues. It's a double-headed monster, which is sort of, $6 billion in the US is being spent in heart failure management last year. And you can imagine what sort of money is being pumped into heart failure. And we all realize there are a lot of new things happening in that area. And I'm sure that, Dr. Manokar will give us some clear ideas of what's the future of this management of these patients. So Manokar, hand over to you.
Yes. Uh, Good evening, everybody, and sorry, good afternoon, everybody. Many thanks to Dr. Ajit sir for providing me this opportunity to be speaking on this forum. I always had a passion towards heart failure, and I always thought when patients come to ER, the ER doctor traditionally assumes that either the patient has heart failure or the patient has myocardial infarction. So our postgraduates, ER people, they have this concept as if these are MI patients, these are heart failure patients. Unfortunately, I always felt that these two interact and kind of make things more complicated in the same patient, and then the things are far more difficult in terms of management strategies, in terms of outcomes, in terms of so many other issues. So that's why I thought I'll throw some light on this two entities occurring together in a clinical presentation and how it changes the way we look at the treatment strategies, the diagnostic tests that we do, and eventually how the outcomes change in these patients when these two strategies occur. So I'll start with very basic things. It's nothing special. Moment a patient comes to a hospital with acute myocardial infarction. So we'll start with patients who have acute myocardial infarction to begin with, and then look at how heart failure in those patients change the outcomes of those patients, and how later on we'll go to heart failure and patients having associated acute myocardial infarction. So this is something I think everybody is been taught maybe for the last 10, 15 years, that when you look at patients with NSTMI, they have poorer outcomes at 30 days and at 1 year. So this is something everybody knows. When patient comes with an ST elevation, there's a slightly increased risk in the initial hours of hospitalization, but over a period of time, in hospital mortality or case fatality in an acute myocardial infarction is with STEMI or NSTEMI is more or less, NSTEMI is the same in hospital for most patients. But at 30 days itself, the graph diverges. And by the end of 1 year, everybody knows that people who presented with NSTMI have worse outcomes. So there's no ambiguity about it. And NSTMI is a bad marker of outcomes in patients. So why it is that we'll come to it at this. So when we look at predictors of 30-day as well as 1 year mortality in patients who underwent a primary PCA for ST elevation. So now within MI, I'm going into the ST elevation MI, and then I'll talk about non-ST elevation. So even in patients that presenting with ST elevation MI, if you look at the pattern, so these are the typical predictors of 30 days mortality and issues like the point I want to highlight here is, if you look carefully in this, if you look carefully in this univariate analysis, many of the factors which contribute to 30-day mortality, if you look at it, and then you look at the 1 year mortality, so many of the factors just disappear. For example, uh, uh, patients who uh, patients who had Achilles class to begin with, patients who had multi-vessel disease. These things do not contribute to 1 year mortality, but the ejection fraction, age, diabetes, they continue to remain as important univariate predictors of mortality. Now, when you look at multivariate analysis, again, the same points come up. If you compare the risk factors, you will clearly understand that the patients with EF less than 30%, patients who have a Phillips class greater than 2 have a higher mortality at 30 days. So this is the multivariate analysis. Okay, I'll just go through. This was the univariate analysis, and this is the multivariate analysis. And if you look at it, Phillips class, all these things contribute in 30-day mortality. But when you look at 30-day mortality and then 365-day mortality, now EF becomes the most important predictor of outcomes. So if you combine both the pictures together, we clearly understand that patients who have a low ejection fraction due to their MI, eventually they have poor outcomes when you look at 1 year mortality. All other things are less important when you look at 1 year mortality, although at 365 day, at 30 days, the other issues, whether it's an anti-revolve, MI, Phillips class, all those things matter early. So this is the prediction model. So if you look at this model to predict patients with in-hospital mortality, so if you look at this thing, the interesting thing is age, systolic blood pressure. These are given more important, the creatinine clearance, cardiac arrest. And look at the troponins, whether it is ST elevation or not, all those things are less important. Heart failure and ST elevation have more or less the same importance when it comes to predicting acute myocardial infarction risk for patients in terms of in-hospital mortality. So it looks very simple because if you add up all these scores, so this very nice article by Namara in JAC 2016 says that if patients have points less than 30, so you can expect the in-hospital mortality to be very low. At the same time, if you have more than 60, then you expect the in-hospital mortality to be in the range of 40 or more, and others fall in between. So this is a very simple way to predict patients with heart failure, patients with acute myocardial infarction, and the importance of heart failure in these subset of patients. Now, I discussed about how to predict outcomes in patients with MI and the importance of heart failure. Now I'm looking at patients who are getting admitted for heart failure. So when you look at patients that are getting admitted for heart failure, this is from the optimized HF data, and this is a nice paper by William Abraham from Ohio. And if you look at these patients, now if you look at these patients, now the parameters change a little. So whether the patient, blood pressure of the patient, creatinine, if the patient is hypotensive, has acute renal shutdown, that is probably the worst outcome in patients in this. So again, a similar protocol if you bring in the picture. So if you look at these things, age, heart rates, because these are all expected things. The new thing is whether the patient is having hyponatremia or not. Presence and whether the primary cause is heart failure, whether the LV systolic dysfunction is there or not, and creatinine is an important thing. So it looks like a very good model because in terms of prediction, it is like a real sigmoid curve and a very clear prediction in terms of probability of death. Now, I'm talking about the third subset. So I first talked about ST elevation and what happens when heart failure happens. Then I talked about what are the factors predicting heart failure outcomes. Now coming to when heart failure happens in the setting of non-ST elevation. So when patients have acute heart failure following discharge with patients with non-ST elevation MI, so the important is what happens first. So if the patient has non-ST elevation MI first, and then over a period of time, patient gets re-hospitalized with heart failure. So if the first level outcome is the patient has heart failure, and the first outcome is the patient has MI. So see how the outcomes change. So if you look at the top half of the graph and the bottom of the graph, you understand that when patients with non-estivation MI, if they get re-hospitalized with heart failure, the numbers turn out to be more bad And I know it's a busy slide, but the importance is patients after non-ST elevation MI, if they go on to develop heart failure readmission, their prognosis is pretty bad. So compared to ST elevation MI, in non-ST elevation MI, the chances of patient having heart failure deteriorating the patient is higher than patients with ST. So why heart failure is deadly in the background of non-ST elevation. So the previous thing looked more confusing, but this is pretty clear. So somebody has non-ST elevation MI, acute heart failure, the cardiac case fatality is almost like 25%. Whereas patient has no heart failure, the mortality is to the tune of 10%. So if you look at the 1 year follow-up, 1 year itself, the graph separates dramatically enough for you to understand that the hazard ratio, post-discharge heart failure, is hazard ratio is somewhere in the range of 2. And this is how heart failure in these patients is so important. So now again, going into further things, if the heart failure, the previous slide, if you see carefully, I was talking about the second admission. But now I'm talking about heart failure occurring in the index admission. So somebody develops heart failure in the index admission, you can clearly see that on day one itself, the mortality and those things are increasing significantly. So now this is summarizing both the studies, the previous one and the same. If you look at post-discharge heart failure, the hazard ratio is 1.6, whereas post-discharge MI, the risk is 1.5. That is, patient has NSTMI, goes home, has heart failure, then comes back with the heart failure, the outcomes are bad. So if you look at this, again, this is the factors that matter in heart failure. If you look at these things, these are things which we all are aware of. Post-discharge MI occurs before heart failure. The creatinine is down, COPD, prior history, EF less, Phillips class more, age, all these things matter in heart failure. So put it in a nutshell, heart failure so if you look, so if this is just to summarize that when you look at patients who have MI and heart failure and all-cause mortality, so if you divide these things, so it gives us a ability to predict people who will develop bad outcomes. So this is an attempt to predict who will develop heart failure when they have an acute coronary syndrome. So this is a model trying to predict. So they have looked at factors like age, Phillips classification, previous EAD, EF, presence of anemia, peripheral artery disease, diuretics on admission. So these can be used as a tools to predict patients who will develop heart failure. Now, coming to the final part of my talk, where I wanted to discuss how the clinical management of patients get affected when they have a combination of ACS and ADS. So, when patients have acute coronary syndrome and acute heart failure. So, what is the diagnostic dilemma and how the patients, there is a confusion as to how these patients should be managed and how the parameters can change. So this is from the European Society of Cardiology and from the European Journal of Heart Failure, and it's a position statement on how to approach it. So this is a busy slide, but what they are trying to say is that any patient with heart failure, if he has chest pain, uh, then that would be the first thing. So there are four presentation first. The patient who has a heart failure has chest pain and a normal cardiac troponin. The second situation is patient has a heart failure, elevated troponin, but no chest pain. The third situation is a patient has heart failure, chest pain, and an elevated troponin. So these are all acute heart failure presentations with uh, chest pain as a. The fourth is the other one. Patients who have present with ACS and subsequently develop AHS. So these are the four clinical scenarios you can have. So I'll repeat the same. You will have four clinical scenarios. Patient has acute heart failure, has chest pain but normal troponins. Patient has acute heart failure, elevated troponins, which could be a marker of myocardial damage just in heart failure but without chest pain. The heart failure, the third category is patient has this thing, but chest pain is there and troponin is elevated. Although the picture is more consistent with heart failure than with ACS. And the fourth subset of patient is patient who has ACS subsequently developing acute heart failure. So these are the parameters that can be kept in mind. So if you look at the clinical dilemmas, so most of the patients can have ECG which can be normal or non-diagnostic. Patients can have troponin which is elevated or can even show dynamic changes. The imaging can be normal or non-diagnostic. Uh, Imaging is always tricky because you have to demonstrate a new loss of viable myocardium or a new onset regional wall motion abnormality. Typical dynamic changes of troponin. The ECG should be very typical of diagnostic of ischemia, and you have to balance between the patients who are best managed conservatively versus patients who benefit by a urgent coronary angiogram and refer. So this is how patients with acute heart failure, the four scenarios, the test and the treatment options will vary even in an echo scenario. So the echo dilemmas would be where a patient has an acute coronary syndrome, has an old MI, and a complications of, or may present with a complication of myocardial infarction. So in fact, I still remember uh, um, uh, there, there used to be echo reports mentioning anterior wall MI, and many of the consultants have this habit of writing non-dilated L. So when I was discussing, one of them mentioned the message that they want to convey is whatever happened is a recent onset event. So sometimes these are locally used terminologies, but they're very difficult to practice in real clinical practice. But when we look at new ACS, if you have an ischemic MR or you have a very clear evidence of a acute posterior papillary muscle tear or things like that, these are evidences that these are new ACS. And at the same time, patients could have changes of an old MI, and some of the patients could be having a MI complication, like an aneurysm, pseudoaneurysm, or infarct expansion and progressive remodeling. Same thing with, comes to when you go to the cath lab. So what happens is angiogram contrast may worsen the renal dysfunction in the setting of heart failure. That's always a concern. And troponins can be elevated just because of myocardial injury rather than because of MI. Coming to treatment, every aspect, the absorption of drugs is affected in patients with heart failure, plasma proteins, hepatic impairment, hepatic congestion, renal excretion, all these things can be affected. Similarly, dual antiplatelet drug, higher risk of bleeding in patients with hepatic dysfunction and may need dose modification or change of drugs. Opiates, definitely we have a big concern about increased mortality in patients with heart failure. Beta blockers, very clearly, intravenous administrations are contraindicated in patients who are could benefit. In fact, most of us are nowadays not doing intravenous beta blockers. Intravenous administration could worsen heart failure. We avoid even oral beta blockers unless the patient is off IV diuretics until the patient is hemodynamically stable and we are convinced that the congestion levels are managed. Coming to ACE inhibitors, renal impairment in the setting of AHF may worsen with initiation, monitor hypotension in the setting of AHF, and MRA, again, renal impairment, potassium, glucose lowering. We have to be very careful with drugs like diazepam, and even DPP-4 inhibitors are not safe in patients with heart failure. Verapamil definitely should not be used in patients. So, summarizing everything, so post-infarction heart failure, when you look at this thing, we have to understand that heart failure complicating myocardium is common. It may be present at admission or may develop during hospitalization. And there is a strong degree in patients with MI, there is a strong relationship between degree of heart failure and mortality. So the optimal management of patients with heart failure complaint varies according to the time and onset of infarction. So medical treatment early, initiation of angiotensin inhibitors alternatively in patients with shock, avoiding beta blockers, and long-term use of beta blockers in the later is also important in this patients. Early revascularization also helps in these patients. So again, summarizing the important pharmacological insights, beta blockers definitely early is harmful, especially in patients with setting of heart failure. ACE inhibitors again are better provided the patient has this provided there is no evidence of acute kidney injury. ARBs are indicated in patients insolvent to ACE inhibitors. aldosterone antagonism, definitely in patients, the early initiation of aldosterone in patients could be a better in early revascularization as soon as possible is the only therapy which helps in patients. Mechanical circulatory support in MA setting, routine use of ABP is not useful or managing cardiovascular shock. So again, summarizing the recommendations, ACE inhibitors, class 1 recommendation, beta blockers, provided the patient has this thing. I think we'll skip this. So, but still, what needs to be further done is prognostic differences in patients with acute heart failure on admission. Develop AHF is needed, and better characterization of type 2 MI in patients with heart failure because it has implications for prognosis and treatment. Type 2 MI needs special attention with respect to heart failure. Improve detection of ischemia in patients participating heart failure and develop validated diagnosis to rule in patients with AHF and ACS and the role of biomarkers in this subset and to improve interpretation of ECG findings and echo findings in patients with heart failure and ACS. And always this the very important thing is the strategy to improve the implementation of angiogram and revascularization in patients with AHF, when to do, when not to do, methods to manage patient stability to facilitate these procedures, and studies to understand the influence of on other therapies.
Thank you, Dr. Manokar. Hello.
Yes, sir.
Yeah, thank you, Dr.
You're
Manokar,
good, sir.
for
We can hear you.
yeah. So making this presentation of heart failure with MI and telling us what adversely affects the prognosis when you have both of these together, and how we should manage this group of patients early and in the later scenario. So maybe we'll divide the panel discussion into two parts. The first part related to the first talk, and then the second part, maybe another 10 minutes on acute MI and heart failure. So let me start off with the first lecture. And basically what we are now going to talk with Prabhakar said is a group of diabetic patients whom we are now going to use RAS blocking. So in primary prevention of patients with diabetes, you have three areas which are a bit confusing. One is, do we need to treat every diabetic with a RAS blocker? Number two, do we need to treat every diabetic with a statin? And number three, do we need to treat every diabetic with aspirin? And to start rolling this through, because these are the three drugs which we have, apart from the diabetic medications, which we have in an armamentarium to prevent coronary artery disease, and to leave each of it outside and isolate them and to talk only about one drug is silly, because most patients will, as you saw, 50% of diabetics are hypertensive, 75% of diabetics are hyperlipidemic, and you turn the thing the other way around, also, they will be the same number. So most of these are a mix of patients. So I think that we should not isolate these things rather than combine it. It's a group of metabolic syndrome disorders, and we need to realize that these patients deserve these treatments to the best of their candidature. So let me start off straight with Prabhakar first as to, okay, now you told us about diabetes. There's a 20% group whom we are not sure in terms of clinical data that whether we should use an ARB. What about statins? Just to go off the record, just to quickly say that, go off the
Sir, my
topic.
impression of statins very clear. All diabetics must be taking a statin because there is nothing like a low risk diabetic.
Right.
So it starts with moderate, and your LDL cholesterol has to be 70, which is not going to come down without a statin.
So that is clear now that you have statins. What about aspirin?
So what happens is all the aspirin trials, the physician health study showed there was a benefit with aspirin because those days statins were not available. So once all the statin trials started coming in, we found out that the statin probably stabilizes the plaque. You don't need the aspirin. So once you start hitting them with statin, you really don't need the aspirin. So good.
Absolutely. That's a very good topic which we have initiated discussion. So if I put my 3 drugs on my table, apart from the diabetic medicines, it sort of becomes clear that the statin has to be taken for a diabetic. As far as a RAS blocker, personally, most of my patients will get it because of Prabhakar's, defense in a way that we need to downgrade the 81 and upgrade the 82 as much as possible, and also get the bradykinin effects, the kinase pathway benefits in patients with diabetes. So most patients will get RAS blocker, preferably an ACE inhibitor, because you get also an advantage of the kinase pathway. And finally, aspirin will be for a very small group of patients. And those group of patients who are diabetic, we clearly need to be clear that those are patients with proven ASCVD, maybe with plaque somewhere noticed that there we will have aspirin. So let me just pass this question around to Dr. Alan. In your practice of diabetic patients who enter, leaving the diabetic medications aside, do you use RAS blockade for everybody?
Yeah, I use for all diabetic patients.
All patients.
80%
Yeah. So,
Prabhakar has convinced them. The other 20%, what I feel is anyway they are you have diabetic, being diabetic is a CAD equivalent. So when you are a CAD equivalent, you are at high risk for CVD. So you automatically need it. And moreover, you are prone for heart failure, you are prone for diabetic nephropathy. So in my practice, once you are diagnosed diabetes, they will get an ACE inhibitor, they will be getting an statin. And as you said, aspirin, select few, maybe who are at very high risk, who have more than 3 risk factors, etc., will get an aspirin. But ACE inhibitors, I start for everyone.
okay. Can I ask you another question, Dr. Alan? If you have an option of using an ACE inhibitor versus an ARB for a primary prevention of a diabetic, what would you choose and why, both for cardiovascular risk and for renal risk? So can I have some thoughts on that?
I primarily use an ACI inhibitor as a first line choice. Only if patient is intolerant to ACI inhibitor, then I use an ARB, especially for CAD protection. Because we know we had a ARB, MI paradox, though later on target trial did not show that, but still there is a doubt. And if you look at meta-analysis, ARBs don't seem to protect from MI. So I would definitely use ACI inhibitors as a first line choice, and only if intolerant to ACI, I would switch to an ARB.
So it's very clear, the HOPE study was very clear for cardiovascular risk reduction with Ramipro, which was the drug proven. Yes, on target only showed equivalence. It did not show superiority. It was a non-inferiority trial. And we always have this question of meta-analysis showing the paradox. And we're not going to go into these meta-analysis because there have been many, and last 20 years, some people have lived their lives on this meta-analysis of ACE versus ARB. So I'm not going to discuss this anymore. But clearly, when there is a drug which has shown clear benefit and with no downside, except that the issue of cough may be an issue which make patients intolerant, where you go to ARBs. But I think in general, it is very clear that we would like to have an ACE inhibitor for the control for cardiovasculars. So can I throw the next question to Pramod, that you have these patients who are diabetic, they don't have any, they're young, say they're about 30, 35, they don't have you have not proven ASCVD in them, and you have a microalbuminuria in these patients. They come to you as their first end organ as microalbuminuria. And then you choose, obviously you have to have a RAS blockade in them. So what would you use, Pramod, ACE or ARB in these group of patients?
Manoj, unmute yourself. Pramod, unmute yourself.
Most of the time, I prefer to use only ACE inhibitors as the first line drug. And some patients whom I don't have close follow-up, and where they're going to come up after 6 months or 1 year, then I choose to start ARB, because sometimes if they get cough and other thing in between, it will be stopped completely. So I prefer to start. At the time, I prefer to start only ACE inhibitors.
If we don't have a nephrologist here, and if you had a nephrologist on this panel, he may have turned around and told us, no. I would prefer an ARB because some trials have shown ARB advantages compared to ACE inhibitor advantage, and we are all cardiovascular physicians, so we seem to have a preference to ACE inhibitors over ARB in most of the patients, whether it is cardiovascular risk or nephrology risk or even stroke risk. Perindopril has shown very clearly that advantage. So I think that overall as a drug, I think RAS blockade, if I can conclude from these small discussions we had, is for most diabetics. It would be very, very unusual that I would not use a RAS for a diabetic who comes to my clinic, number one. Number two, that an ACE inhibitor would be preferential to an ARB in most cases because of the kinase pathway advantage and multiple blockage pathway advantages with the ACE inhibitors. The evidence is also favoring an ACE inhibitor. An ARB would be usually in ACE inhibitor side effect group of patients. Let me throw the next question possibly to Manokar. In this era of ARNI, is there any trial with ARNI which use it for primary prevention, say in a diabetic? Do you have any data of this? Any of you, if you have any data, Manoj, I'll ask Manokar first, but if anybody else has any data with ARNI, because that's a competing now blocker coming in, do you have any data for primary prevention in diabetics?
How about unmute?
So there are, I think it's a transition study or some I forgot the name, with ARNI in acute heart failure. And they have shown it to be pretty safe in patients even before discharge. So there is definite data to suggest that ARNI can replace these drugs even in the acute setting. In fact, there is some interesting data as to what happens to ARNI when as compared to ACE and ARBs in patients with borderline hypotension. So there are some interesting findings that in patients with borderline BP like 90 odd, somehow ARNI produces a better improvement in blood pressure as compared to ACE and ARB drugs.
Yeah.
So
Manokar,
there is
to interrupt you, the question was not in heart failure. The question was in diabetics as a primary prevention. Do you have any data?
I am not aware of any such data in primary prevention. Sir. Sorry, I got it about heart failure.
No problem. No, it's the question is, so basically let me put that anybody has any data with ARNIs in primary prevention? No, I don't think, I personally don't. And I don't think there's any large studies. Prabhakar, you're saying something, put your mic on.
No, there is no primary prevention. There's no studies also in the pipeline on that. Hypertension, I think there are a few studies in the pipeline, but nothing concrete. Even as an indication for hypertension, it is not there. It's only in heart failure that we have data. Heart failure with the preserved ejection fraction obviously failed, and the reduced ejection fraction clicked tremendously.
So let me conclude this.
I don't think there's any data outside that.
So let me conclude this first discussion that if you have a diabetic who enters your clinic and you are deciding about what to treat, most of them will get a statin apart from the diabetic medicines, and most of them will get an ACE, and if they're ACE intolerant, an ARB. There's no data with ARNI, so you should not use an ARNI for primary prevention in a diabetic for cardiovascular disease as of now. So this would be our first point which you would take. And in nephrology part, again, ACE and ARBs are very good. There are larger trials with, unfortunately, there are lesser trials with ACE and more trials with ARBs in the kidney. And therefore, maybe, they seem to be showing that maybe there's an ARB advantage in the kidney part of the story. But I'm sure we mostly use ACE inhibitors in both group of patients for kidney and cardiovascular risk. And for stroke, surprisingly, many of the drugs did not show, if you look at isolated studies with captopril, for example, you didn't show a stroke advantage, but with perindopril, you got the stroke advantage. So clearly, there are certain drugs which seem to have a better stroke advantage, and maybe because they're more potent and because a blood pressure reduction is more important for stroke than many of the other issues which come with stroke reduction. So I think that when you look at a diabetic and you look at his problems are kidney, stroke, and heart attack, I think all fits in with RAS blockade. ACE seems to be preferential, ARBs for those, and ARNIs don't have data. So that would be possibly to sum up the first part of the lecture, of which nicely we dissected it out to say that this is the scenario. Now, let me ask the next question, which is pertinent to the same group of patients, and that is a diabetic whose serum creatinine is 2.5, who has CKD, and now comes to you. What is the role of RAS blockade? So let me again start, possibly with Prabhakar, and then go down what people think in these group of patients. The creatinine 2.5, obviously below 2.5, everybody uses, RAS blockade because it protects the kidney. But here's a clear-cut CKD guy, but patient is 2.5 creatinine, diabetic, long-standing. What's your role for ACE, ARB?
So the practical difficulty has been monitoring these patients and their potassium. That is our biggest, let's say, mind block or a thought block or whatever happens, because you're more worried about the potassium and suddenly landing up with hyperkalemia and crashing. But technically, on paper, yes, there is enough data to say that you can still continue to use the RAS blockade because there are beneficial effects beyond that point also. So you can continue them with a very careful monitoring of potassium. But practically, these patients don't come back to follow up. They don't come to you, and they, after some time, they have some vague fatigue, tiredness. They go, and if we don't stop it, somebody else is going to stop it. That is practically what's happening. But data-wise, I think you should not stop. I think you should be continuing because there is benefit of RAS blockade even beyond 2.5.
Okay. Now, Aileen, do you have any comment on that?
I mean, I feel that diabetic patient, even if his creatinine is high, AC inhibitor is the only drug which is going to retard the progression of CKD going into end-stage renal failure or for dialysis. So he should get. But as Prabhakar said, monitoring potassium is a problem. Anyway, that is nephrologist's headache. So I won't think of stopping an ACE inhibitor even if the creatinine is high.
Pramod, Manokar, any different things that you do?
Yes.
Or
in fact, I put up the point to a nephrologist. So he said, why are you so worried about it? He said that he makes it a mandatory rule for every patient who is having a creatinine more than 3. So he's on this thing to do potassium on a 15-day basis routinely. So he tells them that don't even tell me the reports. Keep on doing potassium every 15 days. And at any point of time, it is more than 5.5 or 6, they are asked to report to the ER. So that is how he manages. So the nephrologist is pretty confident that if you are educating the patient about this thing, you can easily manage. So I think all of us also can try to stick to the same regimen in case we give patients beyond creatinine of 3. If we give AS or ARB, we can also tell the same thing to ask patients to do potassium every 15 days and revert back if there is any high value. And the nephrologist was pretty confident.
Okay, so I think what we can conclude is, yes, there is a definite advantage with the RAS blocker in all group of patients, but the important thing is the potassium, and we need to be extremely careful with potassium. Now, there was one topic which Prabhakar touched in this topic, which I needed to get a little bit more clarity on, and that is MRAs. You have a diabetic, and you started the RAS blocker, and now you're deciding whether we need to add aldosterone blocker. And this is especially relevant when you have two groups of patients. One is heart failure patients with diabetes, and number 2 is a diabetic patient who has some other complications which require either spironolactone or epineuron as a drug. And we saw from his work and presentation that they seem to be weak in certain ways, and they're not alternatives to RAS blocking. They may be additive to a RAS blocking. So let us remember that very clearly, that the first drug which goes in the pipeline in a diabetic is a RAS blocker, even if he's in heart failure. The second drug only comes in is aldosterone blocker, and you could choose whether it is, spironolactone, or you can use epineuron as you wish, but it only comes in number 2. But when you combine these two drugs, especially in a diabetic, be very, very careful with hyperkalemia, because these patients will definitely at one point in a day, especially when they have either an infection or dehydration, usually diarrhea, these patients will land up with hyperkalemia and with some tachycardia and problems into your ER. So I think it's a good drug, especially in a diabetic with a problem of heart failure. You have this issue, you get a good combination of this, but I think it is important to watch for hyperkalemia very, very carefully. And I will not add a drug like aldosterone blocker movement. Your creatinine is more than 2.5, especially if you've started a RAS blocker, because that is going to create a definite hyperkalemia in most patients and get you into trouble in the hospital or outside. So, Prabhakar, you have a comment on that, and then we move on to everybody else.
Creatinine 2.5. The second one is your baseline potassium of 4.5. Only those with the baseline potassium more than 4.5, when you start the aldosterone antagonist, they go in, the MRAs, they go in for a hyperkalemia. So less than 4.5, even in hypertension or even in heart failure, those patients usually do not go for hyperkalemia.
Yeah. So we published this. In fact, I was one of the authors of the Ephesus trial, and we had a subset of patients which was published in American College of Cardiology, which had exactly this issue. But at what potassium would you not add MRA? And one group which you likely, this is from the Ephesus with raised potassium study. And this 4.5 number came out of that study, that if you have potassiums which are high at baseline and you have heart failure and you're starting, please not be careful. It's not that it's not indicated, but you have to be more careful in these group of patients. But you can straight away go and give it to anybody who's otherwise having lower potassium. Any other comments from Pramod, Manokar, or Alan on this group? That you have a diabetic, you have heart failure, you have started a RAS, and now you're adding an MRA on it. Any other issue which you concern or you don't get concerned about?
So previously, any heart failure patient with a beta blocker, AC, and an MRA receptor antagonist was a class 1A indication. Now, after ARNI came, they are saying replace AC inhibitors with ARNI. And what now they have found is that when the patient is an ARNI, then whether the patient is on an MRA receptor antagonist or not does not matter. Both groups get the same benefit. So if a patient is an ARNI, then MRA is not required because it will further lead to more potassium retaining and hyperkalemia.
Okay. Any other comment, Pramod and Manokar, on this topic?
Are we going to discuss heart failure separately, or shall I comment on what Dr. Alan had said?
Yeah, you can talk on what Alan said.
There's a very good review article by Greg Fonaro on heart failure management. He calls the 4 pillars of management of heart failure. So in a chronic heart failure with reduced ejection fraction, the 4 pillars he calls are: 1 is going to be an ARNI, 2 is a beta blocker, 3 is an MRA, and 4 is an SGLT2 inhibitor. Now, if you put all these 4 drugs on board, the number needed to treat to reduce 1 death, mortality reduction, is 4. You just have to treat 4 patients for 48 months. That's a period of 2 years. 2 years, over a period of 2 years, not 48 months. Over a period of 2 years, you treat 4 patients, you're going to reduce 1 mortality. So that is very clear, where even MRA is included on board.
Yeah. So let me put this again. We're not going into a discussion of heart failure yet. We're still on the preventive aspect of diabetic patients who have multiple issues. Either they are, low risk inverted bracket diabetic or everything else, which is the 20% you're talking about, whether we need to do anything. The forum says clearly we need to RAS blockade them. Diabetics with complications, MI, no confusion; hypertension, no confusion; hyperlipidemia, no confusion; heart failure, no confusion; CKD, no confusion. So I think it is over the board that you have a RAS blockade advantage, except for certain caveats. Watch your potassium in the CKD patients. If your baseline creatinines are high, watch for the MRA RAS blockade combination that can create hyperkalemia, and keep a watch on blood pressure so that these patients are well treated in this combination. So next, I suppose we have discussed this threadbare as to diabetics, how we treat with RAS blockade. And then we now go into the next topic, which is what Dr. Manokar said. And that is a very, very interesting group of patients who either have acute myocardial infarction and come to you with a heart failure, acute heart failure, or they have acute heart failure and they developed a myocardial infarction in the same sitting. And the very simple, nice slide showed you 4 scenarios. That simple slide showed us simply that you can have 4 groups of patients. A patient who comes with an acute heart failure who has no chest pain and no troponin rise. A patient who has acute heart failure who has no chest pain and a troponin rise, which is possibly because of acute heart failure itself. Third is a patient with acute heart failure, chest pain, no troponin rise, and who comes with heart failure to you. And finally, a patient who has all the 3 things. He has heart failure, he has chest pain, a classical ACS pain, and a troponin rise. And this is very important for us to know because there are 2 types of myocardial infarction. One is the type 1 myocardial infarction and the type 2 myocardial infarction. And we very often go home thinking that, oh, this patient has heart failure, but his STs are not up, he has no chest pain. So his prognosis is okay. The troponin rise is a bit high. So this chap should do better. And there's another patient who has chest pain and heart failure and who has ECG changes and who has troponin rise. And those patients will do worse. The answer is very much no. Whether it is type 1 myocardial infarction or type 2 myocardial infarction, in an acute heart failure, the prognosis is as bad. And we have to understand that very, very simply. And this is something we need to be very, very clear. And this confusion also happened in ST elevation versus non-ST elevation MI. People think in their mind that ST elevation MI has a worse prognosis than non-ST elevation MI, while it's exactly the other way around. If you look at the in-hospital mortality is similar, 10% is what most studies show in a CFR rate. But as you go further down the time, you see that non-ST elevation MI has higher mortality as you go up the time to 30 days into 1 year. And that is predominantly because non-ST elevation MI, the background is such. They are usually patients who are older. They're usually patients who have multivessel disease. They're usually more patients with CKD, renal dysfunction, many of these scenarios which create problems for these patients in the long run. So I think that what we need to be very clear is that we do not make an assumption that if you don't have ECG and change and ST elevation or ST depression, those patients are okay, they may do better. Now, if you have heart failure and your troponin is high, they do as bad. It's a type 2 myocardial infarction as much as type 1 myocardial infarction. Now, the next question, which I would now throw to the panel, is you have this patient with acute heart failure. You've started diuresis in the ICU because he's in heart failure. We know the traditional risk factors, which is Philip class, which is age, which is CKD at admission, which is anterior wall MI, which is basically renal dysfunction, and ultimately an ejection fraction, which all contribute to mortality in hospital 1 month and 1 year. So it's very clear that this is there. But you start the patient on diuresis, and you're in the ICU, and what is the first drug outside a diuretic that you will now initiate in the ICU on day 1? Maybe I'll start with Dr. Manokar because he made this lecture. So let me start. I have a choice of 4 or 5 drugs with me. I have a RAS blocker, I have a beta blocker, I have an MRA, I have an SGLT2 inhibitor like Prabhakar said. Which is the drug and what is the evidence? What first? Can you put on your whatever?
When somebody has acute heart failure, is on IV diuretics, then automatically beta blockers go out of the window. So we do not start beta blockers in those patients. With respect to ACE inhibitors, ARBs and ARNI, definitely the data with ACE inhibitors is more robust than any of the other drugs. So clear-cut ACE inhibitors is a good choice. Now coming to within ACE inhibitors, generally most of our consultants, most of our people are comfortable with the ramipril as a first choice, simply because everybody believes the degree of hypotension with ramipril is the least. That is again a debatable thing. In fact, we are doing one study on perindropil versus ramipril and the impact of first dose hypotension in patients with ACS. So as of now, we will assume that ramipril or perindopril would be a good choice of drug to start off in the setting of acute heart failure in terms of drug to start and then uptitrate. Regarding SGLT2 inhibitors, again, the data in acute heart failure is not as robust. And when you talk to endocrinologists, they have still a lot of concerns about starting in a patient's in acute setting with the risk of neoglycemic ketosis and patients having underlying acidosis and stuff like that. So they are not in favor of starting SGLT2 inhibitors in India. So even for diabetic management, they think acute setting SGLT2 is not a good choice. So I think we should restrict ourselves from starting SGLT2 in the ACS or heart failure settings in acute patients. But coming to the other drugs that you mentioned, we all give diuretics. We all give usually loop diuretics. So definitely we prefer giving drugs like furosemide or torsemide in those patients. Most often we top it up with a mineralocorticoid just to save the potassium. So we will always add a spironolactone in most of the patients. So most patients would receive ACE inhibitors, IV diuretics or oral loop diuretics and mineralocorticoids. I think these three drugs alone would be the first starting drugs in most of the patients.
Okay, so the evidence for most of this comes from many trials. The captopril study, captopril is another great drug because it can be used 3 times a day. We don't have captopril now, that's a different story, but 6.25 was a great drug because you gave it, if you got a hypertension, you could withdraw it. However, the hypertension is with any of these drugs which are less or more, they are long-acting drugs and you land up. So captopril was a great drug. So that is another drug we should remember in this story of heart failure. And number two, I think the evidence for acute heart failure treatment mostly with RAS blockade is with ACE inhibition. It's only after you go out of the ICU that the other drugs like ARBs, which came valsartan, and the Valiant trial, which showed that they were more or less equal. And even the ARNIs, it is not in the acute ICU that the data has come up with the ARNIs. So basically, I think that is very clear that a patient who has this combination of heart failure and myocardial infarction in the ICU, apart from the treatment of myocardial infarction, which you are going to be standardized of treatment, the drug which you possibly add first is a RAS blockade, and among that, it seems to be an ACE inhibitor. Apart from that, obviously, is in heart failure, so you'll start a loop diuretic and not something else. And because their potassiums may go down, you may add an MRA, provided they are not hypertensive, because remember, aldactone can create significant hypertension in patients. So we have to be careful if they are hypotensive that you don't use aldactone on these patients. And beta blockers only comes when the patient is dry. That means he's not breathless, his x-rays are clearing up with pulmonary edema, and that's when you start the beta blockade. And again, a small dose first, so that we are sure that the patients do tolerate it well and don't get hypotensive in this scenario. And it's usually on this second day is when most of us will start a beta blocker in acute heart failure, not in MI alone. MI alone, yes, you can start a beta blocker early, but when you have heart failure, you would not put a beta blocker as the first drug on in these group of patients. Again, with SGLT2, I agree with you. There's no data in acute heart failure to say that you can use SGLT2 in acute heart failure in the ICUs. It's more or less pre-discharge, or most of the studies with heart failure are in the chronic setting. So I think the question is thrown open now to maybe Prabhakar can add some more data.
The same scenario, the ACE inhibitor should be added within the first 24 hours. Right. Because 40% of the mortality benefits of the ACE inhibition is when you start the ACE inhibition within the first 24 hours. It's given as a guideline in the European Society of Cardiology. It's stating that within 24 hours. And you never start a beta blocker within 24 hours in most of the patients wherein you have an S3 gallop or a fluid overload, pulmonary edema. We have clearly said heart failure, so it's not definitely not indicated. The reason SGLT1 and 2 inhibitors have been tried successfully, the soloist has clearly shown that sotagliflozin may be a future drug. It's not yet approved, it's not come in. So maybe we are looking at it in future. The ARNI trial, the only trial that came up in heart failure in the ICU setting is your patient should not on an inotropic support. 24 hours, patient should not have had an escalation of the diuretic, and patient stable blood pressures and all those things, you can still start an ARNI. But ACE inhibitor do not have so much of restrictions.
Right. So I think the ARNI, like a beta blocker, possibly next day. ACE inhibitor definitely on first day. That's what I would take, unless the patient is severely hypertensive, where you have to be a bit careful with any of these drugs when you're starting. Alan, Dr. Alan, any comment on that?
I agree that the AC inhibitor should be started within first 24 hours. Now, the pioneer HF and transition. These two studies have showed that in-hospital starting of ARNI gives mortality benefit. So, in case you are planning to start ARNI, then how do you start ACE inhibitor? Because if you start ACE inhibitor, you have to wait for 2-3 days, stop the ACE inhibitor, and then switch to ARNI. So, in those patients, maybe I would start the same valsartan ARB AC inhibitor, and then 2 days later I can switch on to an ARNI. But if I start an AC inhibitor, I cannot start an ARNI. Maybe I'll have to discharge him and then start. So that's an issue. In select group of patients who are stable, whom you think you can start ARNI in hospital itself and give them the mortality benefit, then I think you need to start an ARNI.
Any comment from Pramod? Pramod, can I have a comment?
Yeah, if the LV dysfunction is significant, the EF is less than 40%, usually I don't start AC nowadays. I prefer either valsartan or ARNI. Most of the time, as Alan said, I start them on valsartan and then slowly convert them to ARNI. If the EF is
Sir, actually, I have a doubt here. See, we have all been traditionally taught that you have to stop it for 72 hours and then only switch over. But in the last 5 years, I have come across at least 10 patients who have inadvertently taking enalapril and ARNI together. And, till I, came to know of that mistake. But surprisingly, not one of those 10 people had any side effect. So I'm just wondering, should we relook this whole thing? Because I know logically, scientifically, we should stop for 72 hours and all is fine. But these 10 people were taking for almost 6 months enalapril as well as sacubitril valsartan without any issues. So I'm just wondering, are we too cautious in this switch?
Well, I think as far as we are concerned, maybe the patient didn't have a problem, but as far as guideline recommendation, I don't think this is allowed. It's like combining ACE inhibitors and ARBs. I've seen reputed nephrologists combining ACE inhibitors and ARBs with very high dose and getting away with it. But as far as the guideline recommendation, you don't combine it. So you don't combine it because you don't want to get a hyperkalemia and get into trouble. In the same way, you don't want to get a severe hypertension when you have this combination and get into trouble. So let us not give a recommendation of these things. So I think, well, it's fair that you can use ACE inhibitors. It's also fair that you can use valsartan because we had the CHARM trial, which and the Valiant, which was used in heart failure patients, CHARM HF and Valiant was used valsartan. Well, the advantage may be that if you want to switch to an ARNI, it is easier with valsartan than with an ACE inhibitor. But, I think it's anybody's choice what you want to do in this group of patients. But I personally feel it's your choice and you can take. The real advantage with ACE inhibitors is the other extra cardiac effects, which if you cannot shift to an ARNI, maybe an ACE inhibitor would be a better drug in an AMI situation to continue rather than valsartan. So you'll be damn sure that your patient with ARNI, if you're planning to shift from valsartan to ARNI, will take the ARNI forever. Otherwise, the problem will be after a few weeks, he says, I don't have money for ARNI. Then you go back to valsartan and then you have an AMI heart failure patient on not the best drug. I think that is where we have to be careful. Comments, Prabhakar?
I have one comment on what Dr. Ilan said. We are talking about a myocardial infarction heart failure. We're not talking about an acute heart failure admission. Post myocardial infarction heart failure, you are going to have an ejection fraction at onset, and therein it is going to vary. You really don't know where he's going to land up with. And all the ARNIs have been proven clearly only at an ejection fraction less than 40%. And if your ejection fraction improves more than 45%, the ACE inhibitor will probably be the best drugs. And looking at it more carefully, what happens in ARNI? ARNI is the addition of the yin and the yang. So you've got the beneficial natriuretic peptide effects and you've removed the effects of the aldosterone and the RAS inhibition. What does the ACE inhibitor do? Effectively, that's what it does. The bradykinin, the kinin system is what is aggravated, is what is improved by the sacubitril. So I think ACE inhibitor itself is a very good alternative, or even I call it a poor man's ARNI. I'm sure all of us agree that ARNI is going to be superior. There is data on it with 20 milligram enalapril, which was questioned a little bit here and there, but it's all there. But I think in an acute myocardial infarction, it is going to be a RAS inhibition that is going to be clear. I think that is going to be the benefit. You can always reassess your patient. You can always shift your patient to ARNI if it is going to be a chronic heart failure with reduced ejection fraction.
More important is the evidence. The evidence is like, for example, your in AMI, heart failure, low ejection fraction, we have studies, AIR studies there with us, with Ramipril. We have no confusion with that. With the ARNI group, like Alan said, with the transition and the pioneer HF, it is before discharge, not in the ICU. So there is where the catch is. Whether can I give the ARNI on day one? That is the question. I can't. So yes, you can give valsartan on day one. That's not a problem. But then we need to be clear that you're going to switch to ARNI and then the patient is going to continue. Alan, comment?
No, you have evidence for valsartan post-MI also.
Yes. Yes.
Enough evidence in valsartan. So you do that, and then if you want to give an ARNI, that's the I am for ACE inhibitors. My first line drug is ACE inhibitors. I am saying only if you want to give ARNI, then valsartan is
the way out. Okay, so that's a very good discussion where we have when to give what, how to start it, and when to give it in patients. The most important thing is the drugs and the dosing. And I think, giving homeopathic doses of ACE inhibitors or whatever your valsartan is not going to make a solution. So you need to go back to the doses which were used in many of these trials and use it appropriately. And I've seen, 2.5 milligram and being given to patients, and then you have, nothing happening to the patient. And this is something which we need to up-titrate these drugs. Remember the drug dosing, you have to look at it properly, whether it's enalapril, whether it's Ramipril, whether it's valsartan, what is the drug which was used, what is the dose which was used in these trials, and use it in the correct dose. Yes, our Indian patients are low weight. You have to be careful that you don't go jump into the highest dose first, but as if they are tolerating the dose, please go ahead sequentially build up the dose and get the maximum advantage of the drug in terms of the benefit of the drugs and the whole scenario of heart failure. Now, Manokar came to another very important question of ejection fraction. So, if you look at this whole story, I think of heart failure and acute myocardial infarction, and you look at a 1-year mortality of patients, any trial, any study, any multivariate analysis, clearly the ventricle and age seems to be the worst prognosticator.
I'll send the location
to you. The rest are important. I'm not saying ignore it. Multivessel disease is bad. CKD is bad. I'm not saying that it is not bad. But if you look at one shot, the absolute risk which you can see, the furthermost you will get is with ejection fraction less than 20%. And these two things, remember, would be your worst nightmare when you treat an acute MI with heart failure. And it's very important when you have these two at discharge that you tell the patients that their prognosis is not rosy. You may have treated this patient for your first event, but it's very unlikely that this patient will escape a very quick admission or a readmission for another event in this scenario. Even if you have not done the angiogram or you have not done anything in these patients, I simply look at 3 things when I'm discharging a patient with acute. What is his age? What is his EF? And what is his kidney? If these 3 things are bad, you will rest the case with the patient and the relatives that your prognosis of coming back with heart failure quickly, coming back with an MI quickly, and dying quickly is very high in the first month, in the 6 months, and in the 1 year. And that prognostication is important. However well you treat your patients medically, that however aggressive you are with your patient, that they will get back to you with the problems. So there is a patient and he's going on discharge. He has acute heart failure. He's got an EF of about 30%. Your prescription has been a diuretic, an ACE inhibitor in a good dose, a beta blocker in a reasonable dose. You have MRA in a small dose. And if you are an aggressive cardiologist who has now taken the 5th pillar recommendation, you've added DAPA or REMPA in a small dose, and you're sending the patient home. So you're going to ask this patient how quickly to come for your follow-up, and what are you looking in that follow-up? Are you going to do it at 1 week, 2 weeks, 1 month, and why? Prabhakar?
Actually, there's a very good article written on heart failure management by Ramakrishnan. I really like, the one point that I liked about the article was the first week follow-up. The first follow-up 1 week after discharge is the most important thing, because you get to know his parameters within 1 week, and you will prevent a rehospitalization by adjusting the drugs at that time, because the hospitalizations don't happen that fast. It takes about more than a week to happen. So you catch them at that point, look at weight gain, look at the blood pressure, look at the heart rate, look at all the other factors, optimize his drugs, you're going to prevent this subsequent hospital.
Yeah, I remember reviewing this article, Prabhakar. I can't remember what the name of the article was, but this is one indication where you have a cardiac patient at 1 week coming back to you for after discharge. Because many of the patients will say, okay, you come back after 30 days, after whatever you're treated with. But this patient with an MI and heart failure, acute heart failure, decompensation, it is extremely to do more rigorous follow-up. Because if you wait for that 30 days, before your 30 days discharge summary appointment, they will be in the emergency room again. So I think that this is extremely important, and I think it's a solid tip to take that you bring them back at 1 week. So this discharge summary has to say review at 1 week. And this review at 1 week will be not only for your symptoms, but I would go through the risk profile like potassium and stuff like that, urea creatinine, your diuretic status, weight, because here is a time when you need to adjust your medications correctly. And your potassiums may go up, your urea creatinine may go up, you may develop hypertension. And there is when you have to juggle around with your medications correctly so that you get your optimal dosing of patients. So I think this is an important clinical uptake that you need to do, that you would send the patient home and tell them exactly 1 week later, next so-and-so, please see me in my outpatient for the management of heart failure. Now, I have a patient whom I have discharged. He has come back at 1 month, at 1 week. He's good. I've called him back at maybe a month. He has been stable at 1 week. Parameters are okay. I brought him back at 1 month. Now, at this 1 month stature, what am I looking for this patient? So, Aileen, can I throw this at you? What would I look at this patient at 30 days? My 1 week testing is okay. He's good. Many of the drugs are okay. At 30 days, what am I looking at for the patient?
At 30 days, I would again like to, see his abdominal gut, his weight chart, his intake-output chart, his pulse, blood pressure, of course, urea, creatinine, sodium, potassium, and maybe NT-proBNP also to be repeated at 1 month.
So how would an NT-proBNP help in this patient in an acute heart failure on a follow-up at 1 month? Dr. Aileen, can we just throw some light on that?
Yeah, the NT-proBNP is increasing. I know the patient is going from bad to worse. He might get re-hospitalized. I need to get him in. In case it is falling down now, then I know his prognosis is good. He's improving. So I continue on my medical management as an outpatient.
Okay, so it's an important parameter not to assess what is the prognosis of the patient on the long-term follow-up, but how he's behaving on your medicines. Is his heart failure reasonably well controlled or not? That is what, and maybe you're up titrating of medications. Remember, ANIs, you have to use NT-pro and BNP and not BNP. That's important to remember that on the whole treatment. And this is something which I do. So can I throw this again question to Pramod? Do you do anything differently? You do a 1 week and then you do a 30 days. Do you ask for anything else apart from what Aileen asked for?
No, I don't routinely do NT-proBNP for patients at 1 month. But I think that's the best time where we can step up the dosage of medications, especially, whatever ACE or, ARNI are there. And hello, can you hear me?
Yes, we can hear you, Pramod. Go ahead,
Yeah. And also, that is the time usually I start, if possible, SGLT2. I don't start at 1 week because, we don't know what way the renal function will, go. So most of the time by 1 month, we will know that the renal function would have been stable or not. And that is where I start SGLT2. I don't start before that.
Manokar?
Sir, one point I want to add. In fact, we routinely all talk about potassium, but very often in most of the trials, it is sodium levels which predict outcomes. So at some point in a month, at least, we should check the sodium level of this patient and uric acid. Again, why it is linked in all the heart failure trials, I do not know, but definitely these have some prognostic impact in terms of whether if you look at the Seattle heart failure model or you look at the music trial model. So I think these are not very expensive tests. So at least in the 1 month follow-up period, once sodium level needs to be assessed and probably a uric acid to have some idea onto which prognostic group these people will fall in the future. So I would like to do that test, sir.
Yeah, let me be corrected here, Manokar. I may be wrong what I'm saying, but the sodium number, especially hypernatremia, was an acute heart failure, acute mortality in most of the most of the studies as a predictor. But I'm not sure at the 30 days what sort of sodium number did we, was it hyper, or what was it which predicted?
Hypo, sir. People with hypo at 30 days have very bad outcomes. So
Okay.
somehow in the both the Seattle heart failure model as well as in the music model, sodium is given far more weightage. In fact, there is no mention of potassium in that model. They're giving importance to only sodium values at 30 days in predicting outcomes. In the Seattle heart failure model, uric acid is included, but I still do not know how it impacts mortality. But at least sodium, I think we should be consciously looking for in these patients.
Would anybody do an echo at this point of time at 30 days? You've already done a pre-discharge echo. Would you do it at 30 days?
Maybe do a screening.
I don't think it's required.
Less than 3 months, we are not going to see any change.
So the issue is only one thing, you know, the patient has an EF of less than 30, is an acute MI, is a heart failure. Your 45 days window is for the AICD. So that there is one issue where you may have to think as a primary prevention. Well, we don't do this much in India. That's a different story. But if you look by guidelines, if your EF at 45 days is low, you can in an AMI with heart failure, which is a high risk group of patients, and the EF is less than 35, that you have started all your medical therapy, you have given your time for the medicines. Now, you know, the question of primary prevention of sudden cardiac death is an issue. So at this point of time, an echo will help you to make a decision, yes, whether should we do an ICD or we should not do an ICD. Before 45 days anyway, ICD is not recommended anyway for patients. So that is one issue which maybe you can think of in these patients. Any points on that, you think, Prabhakar?
Sir, one point, sir. Sir, echo is important not for from the LV point of perspective, but from the RV perspective, sir. So these are two observations that I thought is valid. People who have a bad RV, they tend to have better short-term and bad long-term outcomes in patients with LVF. Whereas people who have a very good RV and a bad LV, they have bad short-term outcomes. So comparing the RV function at discharge and at 30 days will give you a very good clue as to which group this patient belongs. We all know that RV function, which is bad, is very good in the short run. It helps the patient come out quickly, but in the long run, it is bad. Whereas bad RV, very good RV with a very bad LV, those people have more pulmonary edema, more aggressive, bad clinical outcomes. So that aspect of paradoxical aspect of RV function is very important, especially comparing discharge and 30-day RV function.
Any point, Prabhakar?
Couple of things. One is your, I'll answer the first thing earlier, what you had discussed, that 30-day, what do you check up? Every time I get a patient with heart failure for a review, I do check the urea creatinine electrolytes because it gives you very, very vital information. One is you want to change your dose of ARNI or an ACE inhibitor, you need this. With an SGLT2 inhibitor, you need this. And without that, you're not going to change the dose. And after changing a dose, you need to check it up. So every time I do check it up. That is one. And sodium itself, if your sodium is low, you're over diuresing the patient. it's very important to advise your patient on a daily weight monitoring, which will save you a whole lot of re-hospitalizations and fluid overload. The benchmark that you say is 0.75 kilograms per day or 2 kilograms per week. If you're doing it, you're going in for a fluid overload diurese. So I think that is going to be a very practical, simple method. You're going to avoid the hyponatremia also, avoid over diuretics, because diuretics are not routinely required in all heart failure patients. So if you're going to manage a good weight management, most of the time you may not require. The aldosterone antagonists, the MRAs, are going to have a reasonable diuretic effect also. And you are on top of which, we are now talking about SGLT2 inhibitors, which are also having diuretic effects, wherein you're supposed to reduce the dose of diuretic. So on top of all that, it is not going to be required. The second point about what Manokar said about RV function, there are two tricky issues to that. RV function itself could be a manifestation of the inferior wall myocardial infarction, wherein it is going to improve over time, and clearly the prognosis is going to be good. The long-term implications of RV function in an isolated left ventricular dysfunction is very tricky. It is going to be depending on the pulmonary artery pressures, the pulmonary hypertension, the end-diastolic pressure, RV function. If it improves over time, definitely patients improve. That is clearly the RV function. Isolated studies are clearly there by echo, but you have to do a very good proper echocardiogram. You have to look at an RV strain. You have to not look at TAPC and say that RV function is good. RV FAC, which routinely nobody does.
So I think that we are now clear that the sodium, potassium, urea creatinine should be checked for multiple reasons. An echo, most of us may do, may not do, but the pre-discharge echo is important to understand these patients. You can follow these up with the echo later. It could be at 3 months or 6 months, but clearly, one of the indications I use it is for a patient who's young, MI, heart failure, when I want to be sure that we're not giving, you may have done a primary PCI, you may have done so many things on that patient, but end of the day, if his EF remains 30, he will one day die of sudden cardiac death with whatever you have given to him. And I think it's important at 45 days to suggest that to patients if they need that scenario. Now, there are a couple of questions which have come from the audience, and I like to put this on to people so that we have complete. So the first question, as per recent ISH 2020 guidelines, in the standard care of a patient who doesn't afford for ACE, ARB, thiazide-like diuretic, what will be the drug of choice for a diabetic patient in stage 3 kidney disease with associated? So they're a bit complicated question, but let me simplify that question. So the first question is that you have to give them an ACE and ARB. That's what we discussed right now. A diabetic patient with kidney disease, the ACE or ARB is important as long as you watch the potassium. Now, for some reason, you're not using an ACE or ARB for whatever reason, patient developed a hyperkalemia or something like that. If the patient has associated reduced ejection fraction, you have very little you cannot use many of the drugs in that group. So then you may have to use a nitrate with hydrolysine combination, which will not create these issues, but will help you for afterload and preload reduction. Remember, this is not the first drug of choice. Please remember, the drug of choice for remodeling of the heart and remodeling of the ventricle, remodeling of the kidney, prevention of is an ACE and ARB. But suppose you land up with a complication of an ACE-ARB like hyperkalemia, and the patient is just not able to hold this potassium with this drug, then one option is a nitrate hydrolysine combination, which you could use in this patient. The second question is, combining ACE inhibitors and SGLT2 inhibitors in heart failure patients, will it worsen the renal parameters? I think this is an important question, and I think what Pramod said was exactly this, that it's not the worsening of the renal parameter. You have a patient on a diuretic, which is a strong diuretic you have given them. You've added a RAS blocker, and on top you've got an SGLT2. And remember that SGLT2 is a diuretic also. So with all this together, you may get a hypotension, you may get a hypovolemia, and these will make the efferent arterioles get into trouble, and your ACE and ARBs may potentiate that, and you may get a rising urea creatinine and potassium. And so it's an important idea, important thing that you measure these numbers at the 30 days and be careful when you're using SGLT2 to bring down the diuretic dose, especially the furosemide. Remember, furosemide only improves symptoms. It has no mortality advantage in the long run. So the faster you get off your furosemide, the better for you. All other drugs are important for the long run because they reduce mortality and event rates and end organ protection in the long run. So I think it's important, like what Dr. Pramod said and what Prabhakar said, that when you're using these drugs, that you need to step down on your diuretic reasonably so that the patient don't get hypovolemic and dehydrated and get into trouble with that. So I think it's an important issue which we need to talk and do. Okay, so we've done all this at 30 days and we are quite happy with this patient. You have pushed up the beta blocker, you have pushed up the ASARB, you have added the MRA, you have reduced your diuretic, you've added your SGLT2, and then you told the patient, okay, not too bad, you're doing okay. You have done possibly an angiogram and whatever revascularized or said that it's not revascularization possible, whatever is over. And now you send the patient over. When is your next review normally for this acute heart failure patient? Maybe throw the question to anybody who wants to take this question now. I think it's the last few minutes. So would you do it at 3 months or 6 months? Let's throw the third month. Okay. Is there any other difference of opinion? No. Okay. So everybody says, yeah, 3 months. So remember, in acute heart failure, you have to be more regular in your follow-ups. And especially in this country where patients don't look after themselves as you want them to be. So I think that it's important that it has to be more regular, and a 3 months follow-up and maybe a 6 months follow-up, and then decide after which what to do. So I think in this broad area, we are now at 12:45, which is 15 minutes over time. We have covered two major groups of patients. One is a diabetic patient, how to handle him with a RAS. We have another great group of patients who present to you which have problems, which is MI with heart failure, how to handle them. And I suppose the symposium has helped us to manage these patients better and know which drug when and how and what dose and when to scale up, when to scale down, and what complications to see for these two groups of patients to prevent vascular disease and worsening of heart failure in both these group of patients. So if there are no more questions from the audience and no more points to be raised from my colleagues,